neutropenia is very high, and neutropenic fever happen in more than 80% of those patients. And it's very important to recognize that it's not always possible that you can isolate the source of infection or the focus of infection in those people who have neutropenic fever. So when their count goes down, they start having fever, they appear sick and septic, but you may not be able to find the source of infection or infectious etiology in up to 50% of those people. And only 10 to 30% of people with neutropenic fever will have bacteremia. What is very important about neutropenic fever is we have to recognize that gram-negative infections are common in those people, and that is the one that is associated with the high risk of mortality. And we need to consider initial empiric therapy against gram-negative when we choose the regimen of the antibiotics. The most common source of bacteremia is usually translocation of enteric bacteria from the intestine into the bloodstream. Less likely is the catheter-associated infections if they have central lines or back line, or they have any device that can get secondary infection, and mucosal barrier injury associated with bacteremia, and that's mainly in patients who have severe mucositis. So the alteration of the mucosal barriers in the mouth due to mucositis can lead to transient bacteremia from the oral pathology. Gram-negative rods, particularly the Enterobacteriaceae, represents the majority of those. Neutropenic fever due to gram-negative bacteremia has a mortality rate up to 7% without any antibiotics. Compared to, sorry, it's 70%. It should be 70%, so it's 70. So there is a typo here. It's not 7%, it's 70%. And with use of empirical antibiotics, then that mortality rate can go down from 70% to 4 to 20%. So that tells you how important it is to administer antibiotics as soon as possible. So initial evaluation, we need to get blood cultures and then start empirical antibiotics. I think the next slide will give those all in a table, which will be easier to understand. So once the patient comes to you through the emergency room department, or you see the patients in the clinic, so you need to take a very quick and concise and a really important history. Mainly, you need to identify if the patient has cancer and received chemotherapy over the last 6 weeks. So this is a very important. And then it comes with fever. So you establish the high suspicion of neutropenic fever. Even before you order the labs, you examine the patients and try to find out a source of infection. You look at the oral cavity, you look at the skin, you examine the lungs, you examine the oropharynx, the abdomen. And patient with neutropenic fever in particular, you need to pay a very close attention to the perianal area. A lot of them, they may have perianal abscesses or inflammation and pain that can be easily missed, and that's maybe the source of the infection in those people. And if not identified and treated appropriately, unfortunately, that can lead to severe complications. The first thing to do after you establish the, the history and physical examination, and you have suspicion of neutropenia, the patient's getting chemotherapy and things like that, then you need to take 2 sets of blood cultures with the labs. So you take the labs and you take blood cultures as well. It's very important that you take 2 sets of blood culture. If the patient has a central line and peripheral line, you take 1 from central line and 1 from peripheral line. If they don't have central line, you may take 2 peripheral sticks, but it needs to be 2 blood cultures. And then and in addition to the complete blood count and chemistry, including kidney function, liver function, and electrolytes, those are very important and help you to identify the severity of the case, and also help you in choosing the antibiotics and risk stratify the patients. If the patient has symptoms of cough or shortness of breath, you order imaging for that. If they have burning sensation with urine or any urinary symptoms, you order UA and urine culture. And so that's your initial evaluation, is you try to evaluate the patient, how stable he is. You order your initial labs and blood cultures. And after you had your initial evaluation, you need to administer chemotherapy, administer antibiotics as soon as possible. Here is a list of the most common bacterial infections that can lead to neutropenic fever. Gram-negatives are one of the common organisms, and most of those are, as we said, translocated from the gut, from the intestine. E. coli, Klebsiella, Enterobacteria, Pseudomonas aeruginosa is one of those that carry significant mortality, and that's why we always, when we choose antibiotics, we have to choose an antibiotics that has a significant activity against Pseudomonas infections. Gram-positive bacteria, those include Staph aureus, Enterobacter, and some of the oral pathogens like Streptococcus pyogenes or Streptococcus pneumonia. And rarely, some of the other less common, you will find some either Candida, other form of fungi, and C. diff infections. Very important is, time is a very critical thing in patient with neutropenic fever, especially if their degree of neutropenia is severe. The sooner that you can administer empirical antibiotics, the better, and that lead to improved mortality in those patients. So in this paragraph or recommendations, the author, and that is consistent with also recommendations from Infectious Disease Society of North of America and also American Cancer Society, is to try to triage patients. Anybody with fever and had chemotherapy over the last 6 weeks, you should suspect a neutropenic fever and assume bacterial infections. So you document the fever, you do your exam, and you take the blood cultures, and then you administer the antibiotics. It's very important to give this antibiotics IV for the first dose at least, and then it needs to be given within 1 hour of triage, and the sooner the better. But if you delay it more than 1 hour, the risk of complications and mortality goes high. So when you do evaluate the patients and then you send the cultures, you give them the first antibiotics, and then in your mind, you do your assessment, how sick the patient is, and you do what we call risk assessment. There's 2 important models that we use to help us identify how sick the patient is, and it would be better to treat this patient either in the hospital or you can send them home. The first is called MASCC, which stands for Multinational Association for Supportive Care in Cancer Risk Index. And that takes into consideration the burden of symptoms. If the patient has severe symptoms, moderate symptoms, if they have hypertension or not, COPD or not, whether the cancer is solid malignancy or hematologic malignancy, if the patient is dehydrated or not, are you seeing the patient in the outpatient status, and if the patient is younger than 60 years old or not. So you calculate the score of this model, which help in classifying whether the patient will be high risk or low risk based on that. And then you use also some other scores. We call it CISNE score, CISNE, and that take into consideration whether how's the performance status of the patient. Is he able to get up and walk, or he's bedridden? Stress-induced hyperglycemia, COPD, chronic cardiovascular disease. Does he have severe mucositis or not? And then the monocytes, whether they are less than 200 or not. So you calculate the score from those 2, and then that will help you to make decisions about management. I know this slide is very busy and you may not be able to see it well, But as we should, this is a very, very helpful paragraph to help you going through algorithm to see how to appropriately manage patient, and whether the patients need to be treated inpatient and outpatient based on all of those. So we started, we start here, and that's, we document the fever, we do our triage, checkup, take blood cultures, do our physical exam, and administer antibiotics. And then based on that, after that, we try to stratify the patient, risk for medical complications, whether he's a high risk or low risk. Then usually we move into the next step. You know, those here is the risk factors, as we talked about, risk for medical complications. High risk patients, those are only some examples, but helps you. Any chemotherapy, or if you anticipate that the chemotherapy will result in prolonged neutropenia, meaning more than 7 days. If the expected neutropenia duration is more than 7 days, then you will need to consider this patient high risk and more likely need to be treated inpatient. If the patient is clinically stable, does he have normal blood pressure or hypotension? Any altered mental status? Is he confused? Any CNS symptoms that you can tell? If their oxygen saturation is low, or their work of breathing is high, if their urine output is low, all of those are considered red flag and high risk signs. You need to take it into consideration. And then you take into consideration the MASCC score and the CISNI score, the one that we calculated initially. Any score that is less than 21 is considered high risk, because most of those scores are actually looking for a good signs: absence of hypertension, absence of COPD, absence of cardiovascular disease. So if the score is 21 or less, that indicates severe illness, and CISNI score more than 3 is considered high risk. So those people will be high risk. And in the other hand, if the score is more than 21, CISNI score of 0 or 1 or 2 in patient with solid malignancies, the patient is clinically stable, anticipated duration of neutropenia is less than 500, then that would be considered low risk patients. Now, if we identified the patient as, you know, we did this risk assessment and we identify the patient either high risk or low risk. If we decided the patient is low risk, we have to take into consideration many other things as well. Is the patient is able to take anything PO? Is he having an intact GI tract? Does he have problems with taking oral medications? Does he have a caregiver at home? Somebody will watch him and bring him back if he gets sick. Does he have telephone to call if he gets sick? And all of those are important. So if he has the right conditions to be treated at home and he has the support he needs at home, then at that time you may think about the patient could be an appropriate for an outpatient management. You give them an oral antibiotics. Usually we recommend Augmentin, amoxicillin clavulanic acid plus ciprofloxacin. But it's very important to give them the first dose of antibiotics as an IV in the emergency department, and then watch them in the emergency department for at least 4 hours to make sure they don't decompensate, they don't develop hypotension, they don't get sick, and things like that. If they stabilize, able to take oral, then you can send them home on amoxicillin clavulanic acid and ciprofloxacin. Now, if the patient does have high-risk features based on the risk assessment, they need to be admitted to the hospital. So you admit them to the hospital and initiate IV antibiotics. Hopefully by now they already received the first dose of IV antibiotics. You just need to decide what will be the subsequent antibiotic regimen that you need to put the patient on. You have also to make assessment. You know, this patient, you already decided they will come to the hospital. They already need to be admitted to the hospital. Then you have to do more assessment, and probably this happened more in the role of the internal medicine resident or internal medicine physician after the ER already did what they need to do. You need to identify if the patient has any signs of severe sepsis or septic shock, if there is any hypotension, mental status change, new onset respiratory dysfunction, decreased urine output, or any specific clinical focus of infections, if they have pneumonia, or they, like in our patients, that they had typhlitis or neutropenic enterocolitis. You need to direct the treatment on that. But generally, based on this assessment, you classify the patient as stable or relatively unstable. If the patient is stable but need to be treated inpatient, then you actually keep them on the IV regimen. Usually you choose any antibiotics that does have activity against Pseudomonas. It's very important to have an anti-Pseudomonal coverage in those people, because Pseudomonas is the one that carries significant risk of mortality in those patients. So you use either piperacillin, tazobactam, cefepime, meropenem, and historionam in patients who are allergic to any penicillins. Okay. Now, if the patient is sick, then you may need to admit them to a higher level of care. You may need to add a vancomycin to cover most of the staph MRSA, mainly MRSA infections. And then you actually just for the first 12 to 48 hours, you adjust the antibiotics according to the cultures and according to the clinical response as well. Usually in people who have a high risk features, then we recommend to add MRSA coverage to those patients. And also patient who had a history of MRSA colonization in the past, then you probably will need to add vancomycin initially. Okay. Now, what happens after 2 to 4 days after antibiotic therapy? Now, if the patient considered low risk, meaning this patient you already decided they are low risk and they treated mainly as outpatient, if they get better, the fever went away, and then you continue antibiotics, their ANC is greater than 500, then you stop after that. If there is resistant fever, meaning the fever persisted after 2 to 4 days, or if they developed any clinically unstable conditions, and their ANC is still less than 500, then you hospitalize them and you administer IV antibiotics, and you take the route to, the inpatient team will take care of them and triage those based on the risk and treatment needs. At any time, if you have the source of infection is already identified, blood cultures grow some certain microorganisms, then you can direct your antibiotics toward that. And adjust that treatment accordingly. For high-risk patients that you decided to admit them to the hospital, if their cultures came back identifying source of infection, then you treat accordingly. But if your workup and cultures remain negative for the first 2 to 4 days, if they are clinically stable but still have fever, meaning they don't develop any hypotension, the respiratory status is stable, they look stable, then you probably need to continue with the same antibiotics and assess for another sites of infection. You may need to do some more imaging, image of the sinuses, image of the abdomen if it has not been done before, image of the chest if it has not been done before. Try to identify sources of infection. But as long as the person is clinically stable, in the day 2 to 4, you may not need to make any changes in antibiotics. If the culture is negative and their fever is better, and we continue IV antibiotics, their ANC is more than 500, then you may switch to oral and discharge if they're clinically stable. Now, the problem if they, at any time the patients become more sick or more ill, then you escalate the care after that. So what happens after 4 days? If after those 4 days and the patient is still having fever, so those people usually are the high-risk patients in the hospital. If they have prolonged fever more than 4 days, every day you do a daily examination. It's very important that you pay attention to hidden sites, and central line sites, perineal sites. Those areas sometimes can hide an infection in those areas. And then you repeat cultures after 48 hours to see if there's any new bacteremias. If the infection is documented and the patient is clinically unstable and worsening signs or symptoms of infection, then you investigate accordingly. But if the fever continued, then you may add some antifungal medications and try to work your way that way. If the fever continued and the patient is clinically stable and ANC is improving, then you may just watch them and then continue same antibiotics. But if the fever continued clinically stable, but the ANC is not expected to recover in a short period of time, then you may add antifungals, and that depend on the type of antifungal will depend on if they already on antifungal prophylaxis or not. If they already in antifungal prophylaxis, then you may switch them to another antifungus. And whether you're suspecting invasive fungal infections like Aspergillus or not. If you are suspecting Aspergillus, then you may need to use medications that has activity against Aspergillus. That usually happen in people with prolonged neutropenia, or there's chest imaging showed any infiltrate or nodularities or nodules. You may need to use voriconazole or amphotericin P or any of the echinocandescents. All right, and other considerations, another very important things is usually we don't recommend to use GCSF, which is Neupogen or any of the growth factors, for routine use in patient with established fever and neutropenia, because the neutropenia already happened. You may not need to use it. Exceptions for that in people with high risk of infection, if they are hemodynamically stable, then you may consider using some growth factors, and that's a recommendation from the ASCO, American Society of Clinical Oncology, but the Infectious Disease Society of America still stand to its position of it's not recommended to use those routine use of GCSF. Now, sometimes patients may have infection around the central lines, or they have a central lines. As a very important things to consider of removing the lines in those situations. If the patient has Staph aureus infections or Pseudomonas infection, bacteremia mainly, Candida species or any other fungal infections, documented bacteremia, then you need to remove the portacath. Also rapidly growing non-tuberculous mycobacteria, or if the patient has catheter side infection like tunnel infection or port pocket infection, then the catheter need to be removed and treated that way. So in conclusion, febrile neutropenia remains an important complication of treatment with cytotoxic chemotherapy. It's very important that you deliver an urgent and appropriate evaluation, and treatment are imperative because delay in initiating appropriate antibiotic therapy may be life-threatening. Selection of antibiotics should be based on the patient's symptoms, previous cultures data, and institutional antibiograms. Ongoing therapy should be guided by culture and clinical data, and antimicrobial resistance is of great concern, particularly in this population who are very vulnerable. So careful attention to antibiotic selection and duration is needed. All right, so we finished with the neutropenic fever, and that's probably the longest emergency that we're gonna spend time on. But now we're gonna move out to another subject or another emergency. We call it hyperleukocytosis and leukostasis in hematologic malignancies. And this is sometimes comes along very commonly. Hello?
تسمعنا؟ دكتور عبد الرحيم.
تسمعونا؟ Hello?
Yes, yes.
نعم. لحظة خلينا أشوف كيف ممكن أصلح اللحظة.
نحن نسمع. We are hearing you.
بس هو لا يسمعنا. قبل الانتقال بس للدكتور عبد الرحيم. تسمعنا الآن؟
الآن أسمعك.
طيب تفضل معليش في سؤال بس قبل الانتقال إلى التوبيك الثاني.
تفضل.
دكتور محمد تفضل.
شكرا دكتور عبد الرحيم. بالنسبة للسؤال خليه الآن ولا بعدين يعني؟
تفضل تفضل.
طيب السؤال حقي اللي هو الجرانيولوسايت ستيميوليتنج فاكتورز هل له أي رول في حالة البيشنت إنه يكون بريستيبل في بايلوتروبينيا أو لا؟ جرانيولوسايت ستيميوليتنج فاكتورز أكيوت سيتنجز.
ممكن تقول السؤال مرة ثانية؟
Granulocyte stimulating factors in the acute setting of febrile neutropenia. Is there any role in the acute setting? يعني should can be given for the patient or should be delayed?
Okay. So علشان بس أعيد السؤال علشان المستمعين الثانيين. دكتور محمد يسأل هل في رول للجي سي اس اف في الأكيوت نيوتروبينيا؟ زي ما حكيت usually there is no rule. عادة خاصة إذا كان solid tumors with duration of neutropenia expected to be less than 7 days. Usually there is no rules. There is some situation in which you may consider using GCSF, and that's in patients who are unstable. You know, some patients who are hypotensive or in shock or severely ill, or patients that the neutropenia may be anticipated to be prolonged. Then you may justify using just the GCSF. But again, the American Society of Clinical Oncology consider that as an option. But the Infectious Disease Society of America actually very clear in their recommendations that they don't recommend GCSF for treatment of established neutropenia with fever.
لو تسمع سؤال ثاني بعدين لو بس مرة.
تفضل.
دكتور, in regard to the monotherapy versus combination therapy في حالات الفيبرال neutropenia, which is recommended? والسؤال الثاني, why vancomycin usually is not recommended or not set as an initial therapy with patients with febrile neutropenia, although there is some gram positive bacteria can cause it. And إن شاء الله واضح سؤالي.
السؤال الثاني واضح، السؤال الأول مش واضح.
السؤال الأول هو موضوع المونوثيرابي versus combination therapy. يعني هل مثلا الكيس اوف febrile neutropenia هل من الأفضل إنه الفيزيشن يعني يحط multiple therapy أو combination therapy مثلا بس دي مع تازوبكتام مع vancomycin مع cover everything, or just إنه stick to monotherapy, for example زي ما ذكرت في CVP أو which one is better option?
أنا أتوقع أنت تحكي عن الهاي ريسك patients اللي هم أنت you think they are sick and they need to come to the hospital. هذا يعني selection of antibiotics also will depend on the previous culture data of the patients. يعني إذا المريض أنت تعرف إنه إجا قبل هذه المرة في عنده MRSA infection أو كان عنده MRSA infection في in the past أو كان عنده resistant pseudomonas or resistant gram negatives. So you probably will tailor your treatment according to that. But in general, somebody that you just saw for the first time, you don't have any information about their past culture history, you go by the hospital biogram. يعني في بعض المستشفيات يكون في عندهم biogram واضح إنه في عندهم high rate of MRSA أو high rate of يعني resistant gram negative. Then you choose the antibiotics that will cover most of those patients. But generally, based on the recommendation, the monotherapy we use it for patients who are low risk. يعني patient who are hemodynamically stable, ما في عنده hypotension, sepsis signs, no altered mental status, urine output is adequate, who considered stable but high risk. You use a monotherapy. You don't need to use vancomycin in those patients routinely unless you suspect an MRSA. لأنه معظم other antibiotics, السيفيبيم, الميروبينيم, piperacillin, tazobactam will have a good coverage for most of the gram positive and gram negatives. Now there is another entity, and I don't know if you meant that or not. Sometimes we use double gram-negative coverage in situations in which a patient present with septic shock or severe sepsis, and there is a high rate of gram-negative resistant organisms, either resistant Pseudomonas or ESBL positive organisms are very common in the area. Then you may add a second anti-Pseudomonas medications. You either add aminoglycosides to the cefepime or piptazo or piperacillin tazobactam, or some people they add Cipro to double cover those. So generally for stable low-risk patients who need to be admitted to the hospital, we don't routinely add vancomycin unless we suspect MRSA infection. If somebody become hypotensive and when they come, they are sick, they are hypotensive, they're in shock, then you start in doublet. You start with both vancomycin and cefepime. And if you have a culture data from the institutions that there is a high prevalence of gram-negative resistant bacteria, then you may add a third medication, double Pseudomonas coverage. I hope that answers your question.
دكتور عبد الرحيم، مشكلتنا انه ما عندنا culture. يعني محافظة شبوة كلها ما فيها معمل culture اصلا، هذا رقم واحد. رقم اثنين، غالب شوف الغالب في المرضى اللي يجوا نيوتروبينيك فيفر في شبوة على وجه التحديد وفي عدن، على حسب علمي يبدو لهم 3 انتيبيوتكس يعني اول ما يشوف المريض، حتى لو المريض فقط عنده فيفر، فقط نيوتروبينيا وفيفر. ف يعني المونوثيرابي، ايش نصيحتك انه المونوثيرابي فقط will be okay if there is يعني just neutropenic fever. يعني sometimes we discharge these people as you mentioned على حسب السكور صح؟ ايش نصيحتك اطباء العموم انه neutropenic fever لا تعني combination therapy؟
Yes, and usually monotherapy is the recommendation for a stable patient. Fever, a stable patient, ANC less than 500. Use monotherapy with either cefepime or piperacillin tazobactam or any other medications. We use combination only if the patient is unstable, hypertension, altered mental status, and things like that. Because you're running a risk of developing resistance with using antibiotics, and those antibiotics has a side effects as well. Use vancomycin a lot, then patients end up with renal disease. And there is complications from the antibiotics in addition to the resistance. So it will be better to use monotherapy in patients who are stable. But if the patient is very sick and unstable, then I probably will justify using both doublet antibiotics.
تفضل دكتور نكمل.
All right, we'll move to hyperleukocytosis. يعني انت يمكن تخيل حالك في الطوارئ اجاك مريض يشكي من fatigue, tiredness, headache, في عنده nosebleed. You order the CBC for him, and you have the CBC came back white blood cell count of 150,000. So what to do? So I think that's the reason I want to get you guys familiar with this emergency. For the emergency physician, I think the most important thing about this is to recognize the problem. I don't anticipate that you probably will treat those patients, but it's very important that you need to be able to identify the problem and make an appropriate referral for those patients. The next step to move those patients to the right place in which they can receive the care they need. So hyperleukocytosis by definition is the increase in the white blood cell count, mainly the blast. We look at the blast count more than 50,000. Some other organizations, they use a definition of 100,000 of those blasts. Now, the leukostasis is a term that we use to describe symptomatic hyperleukocytosis. If you have high white blood cell count and you have symptoms, then you have leukostasis. If you just have a high white blood cell count but no symptoms, then it's a hyperleukocytosis. There is usually the conditions that can lead to hyperleukocytosis are acute leukemias. But it's very important for you to differentiate between 4 possible scenarios that can come through your way. Acute myeloid leukemia or acute lymphocytic leukemia or chronic lymphocytic leukemia, CLL, or chronic myeloid leukemia. Because some of them are very serious and need a very quick attention and treatment. Some of them are less serious and they may be okay to watch those people. So acute myeloid leukemia, usually some of the patients may present with increased white blood cell count more than 100,000. And if the percentage of blast more than 50,000, especially with symptoms, that will consider an emergency, and that patient need to be treated as soon as possible. So if you come to the emergency, you need to refer them to a place in which they can take care of acute leukemia in the hospital. This patient need to be admitted and need to be taken care of very quickly. Patient with acute lymphocytic leukemia is the same. Now, patient with CLL, chronic lymphocytic leukemia, those patients has usually high number of lymphocytes, and those lymphocytes are small and mature, and they are less risky. So it's very common that you may do a CBC on asymptomatic patient. Usually those patients will be asymptomatic and their diagnosis will be based incidental. Like you do a CBC in patients who came for, fractured leg or fractured arm, and then you find their white blood cell count is 60,000 or 70,000. And you check the differential, and it's mainly lymphocytes. Now, the patient does not have any symptoms and has been feeling well and doing well. So this more likely is represent chronic lymphocytic leukemia, and this patient may not need an emergency treatment like the other cases. Chronic myeloid leukemia is very similar to CLL. Most of those myeloid cells are less sticky and not as risky as the blast. And most of the time, patients may not need any acute intervention. The exceptions to those is, CLL may cause hyperleukocytosis only if the white blood cell count is extremely high, more than 300,000 or more than 400,000. Then at that time, it just it can cause leukocytosis by hyperviscosity. CML only in the blast crisis that can cause that. So in the ER, you may not know if the patient has CLL or CML or ALL or AML. If the patient has been, told you that he's been diagnosed with chronic leukemia or CLL or CML, then that will make it easier for you. Unfortunately, that's not the case most of the time. So in those cases, sometimes the lab may be helpful, to ask the hematology technician to look to those cells. Most of the technicians, they may be able to tell, the blast or not. If you are in doubt, I think it will be better to refer the patient for the care they need. بس بشكل عام symptoms of leukostasis. So how to identify that the patient is at risk or having symptoms related to high white blood cell count, because you will have leukostasis of white blood cell count in the lung, and that can cause either dyspnea, hypoxemia, diffuse alveolar hemorrhage, and respiratory failure. It can cause central nervous system symptoms, including confusion, dizziness, headache, coma, sometimes in very severe cases. In the eye, impaired vision, retinal hemorrhage, ears, tinnitus. In the heart, it can cause, acute MI or coronary artery disease. It can also cause thrombosis and ischemia. So if the patient comes with any of the high white blood cell count and they do have any of those symptoms, that should raise the concern that this patient may have hyperleukocytosis and leukostasis. So the initial management of those patients, generally the management is directed at lowering the white blood cell count as fast as you can. Now, if the patient has symptoms, or if they don't have symptoms, but they have the diagnosis established and they already, been in the hospital, the best treatment is start chemotherapy. But that's not the case most of the time, because most of those patients will still need to be diagnosed, and you need to know what exactly the underlying malignancy. So in those cases, sometimes you start with hydroxyurea, which is it helps with decreasing the white blood cell count. In patients who have symptoms and you cannot start chemotherapy because you don't have a diagnosis yet, or you cannot, he is not in a place in which you get chemotherapy, I think the best way to do is leukapheresis. I'm not sure if leukapheresis is available in our country at all, to be honest. But in those patients, sometimes getting the hematologist, oncologist involved very early will be very helpful. Another very important thing, which is very important, those patients most of the time will have anemia. So this patient may come with hemoglobin of 6 or 6.5. And in those patients, it is better to avoid blood transfusion. If you give blood transfusion, you increase serum viscosity, you increase the complications. So in those patients, you probably need to avoid blood transfusion in general. All right, so moving to the next case, acute hyperviscosity is another acute emergencies that develop. Usually we see this either in acute leukemia, like we said, the hyperleukocytosis, but also this can be seen also by increased plasma hyperviscosity from any monoclonal or polyclonal disorders associated with increase in the immunoglobulins. Usually the normal serum viscosity is around 1.4 to 1.8 relative to water, and usually patient will start have symptoms if the serum viscosity is more than 4. Most of the symptoms that patients will develop, will get better if we are able to diagnose and treat quickly. So this is slides here list the causes of hyperviscosity and the symptoms. Usually the most common cause in most of the patients is Waldenström macroglobulinemia. So those patients will present mainly with systemic symptoms, fatigue, tiredness, headache, some epistaxis, some gingival bleeding, some eye or vision problems, or multiple myeloma. Very rarely it can happen in also benign diseases like rheumatoid arthritis, Sjogren's syndrome with very high immunoglobulin levels, hypergammaglobulinemia related to that, very severe polycythemia with very elevated hemoglobin. Usually we see that if the hemoglobin is more than 20 or 22 and associated with very high hematocrit as well. Most of the symptoms will be related to poor circulation and occlusion of the venous or arterial system at the microvascular environments. Gingival bleeding, gastrointestinal bleeding, retinal hemorrhage and thrombosis, and that will be very helpful in terms of diagnostic purposes. Cardiac complications, including heart failure, so patients may present with heart failure. This retinal photograph, you can see multiple hemorrhages here and there due to hyperviscosity. So if you have an ophthalmologist or you know how to use the ophthalmoscope in proper way, that may be another very important sign that you may look for. The way that we treat hyperviscosity, it depends on whether the patient is symptomatic or not. Usually, if the patient has any of the symptoms that we just talked about, then at that time we need to order the immunoglobulin levels and viscosity levels we don't have to wait for those results to come back. You just obtain the test, and then you move into treatment, and the treatment usually is a plasma exchange. So you do plasma exchange over 1 or 2 days, and that usually will bring the serum viscosity very low, and most of the symptoms will get better. And then once you get the serum viscosity better, then you do treatment directed to the underlying etiology. If the patient has Waldenström macroglobulinemia or multiple myeloma, then you get him treated for that. If the patient does not have any symptoms, then or if they do have some symptoms but not at risk, very mild symptoms, very non-specific symptoms, then you measure the serum viscosity and do the workup that you need to figure out the underlying etiology as well. And then if if the serum viscosity comes back high, then you may initiate a plasma exchange. In a low resource environment, sometimes you may not have the ability to run the serum viscosity. So you go by the clinical presentation and the symptoms. If you suspect that the patient has a hyperviscosity syndrome, he is very symptomatic, then you need to get a hematologist involved immediately for consideration of plasma exchange. So as I said, most of the time, the role of the emergency physician or a general physician in this situation is to identify the problem and then refer the patient to the appropriate person. So if you identify hyperleukocytosis or hyperviscosity syndrome, and then you can basically refer the patient to call the oncologist or the hematologist so they can take care of the problem as soon as possible with the resources that is available locally.
If they don't have plasmapheresis, Dr. Qasem, what is the role of fresh frozen plasma in these patients like acute emergencies, TTP, hyperviscosity, الحاجات هذه?
So you would like to avoid any fresh frozen plasma, right? Because any transfusions would increase the viscosity of this patient. So you would like to avoid any blood transfusion and avoid any fresh frozen plasma. You may give them fluids, IV fluids. It may help if they are not in clinical heart failure. You may give them some IV fluids and try to manage the other symptoms they come with, stabilize them, and then they will need to be treated with either plasma exchange or some medications to bring down the immunoglobulin level.
طيب دكتور محمد بيقول in hyperleukocytosis, should we request leukocyte ALP to exclude leukomoid reaction? This is the first question.
If you have the ability to do that, I mean, nowadays we don't do that. I mean, it's a very helpful test to differentiate between leukomoid reaction versus leukemia. But usually the clinical picture will help you to determine what's going on. If you see blast in the peripheral blood, or you see, or if the patient has also severe anemia and thrombocytopenia, then I think that is a red flag for you, and that will be sufficient for you to be very suspicious about acute leukemia or severe cases. In the other hand, most of the leukomoid reactions will not give you an extremely high white blood cell count as more than 100,000, although I have seen some cases like that. But usually there will not be symptoms of leukostasis. You will not see, hemorrhage, alveolar hemorrhage. You will not see heart failure, shortness of breath, thrombosis, and things like that. So it may be helpful, but usually I find it very helpful in a stable patient with chronic elevation of leukocytes. Like patient with CML and they're stable, it may be helpful to tell you on the outpatient basis whether you're dealing with leukomoid reaction versus a myeloid lineage disorder, like chronic myeloid leukemia or acute leukemia. And I think we have not been doing that here for a long time, and I don't know if that test is available locally or not. I mean, if it is available and that's the test that you have, then you can use it. I think it may be helpful.
سؤال من الدكتور شانا علي. For patient with hyperviscosity syndrome presented with MI, which strategy would you prefer, treating MI or plasma exchange?
What did you say the first word, Walid?
واحد جاب hyperviscosity syndrome presented with MI. Which strategy would you prefer, treating MI or plasma exchange?
I think plasma exchange will be very helpful. And it depends on how severe the MI. If it is ST elevation and the patient is unstable and cardiogenic shock, that's a different story. Then you may need to take him to the cardiac cath and try to stabilize him that way. The problem with hyperviscosity, there is increased risk of bleeding and thrombosis at the same time. So if the patient is able to be managed medically, you know, you put them in beta blockers, and if they are able to tolerate, if they are not actively bleeding and they're able to tolerate, you know, aspirin or some of the other medications, I think it would be better to start with the plasmapheresis, because that will bring down the viscosity and may help, you know, restoring the circulation. If the patient is in, you know, acute MI and very symptomatic and, you know, and cardiogenic shock and need intervention, then those are one of those cases that you will need to use your judgment at that time. I don't think there is a clear answer, yes or no, but you know, as a hematologist, I would like to reverse the main etiology for the problem, getting the plasma exchange going initially will help, and to treat the existing condition and to prevent other complications, prevent stroke, intracranial bleeding, and things like that.
تفضل دكتور عبد الرحيم.
Okay. The other thing that I want to talk about is a unique hematology issue called ABL, acute promyelocytic leukemia. It's a subtype of acute myeloid leukemia classified as M3. In this particular leukemia, there will be a very unique translocation of BML RARA or fusion gene, translocation 1517. That will lead to differentiation arrest at the promyelocyte level. So the promyelocytes will expand in the bone marrow, and they are rich in granules that can release a lot of you know, histamine and chemicals that can induce a clinical DIC. Most of the patients will present with general symptoms, fatigue, tiredness due to anemia, and then infections due to neutropenia and bleeding, hemorrhage. The reason I put this here as an emergency is it's very important that you identify this problem because it's highly curable. You know, if you are able to identify the patient and appropriately refer him to the person who want to treat him, and do your initial triaging and properly manage him initially, if the patient survived the first 2 weeks of treatment, which is you know, the period in which the mortality is very high, then there is a very high risk, very high chance of cure. So it's a highly curable disease, but the mortality is very high in the first 2 weeks, and that's mainly due to hemorrhage and infections, which are due to mainly neutropenia and disseminated intravascular coagulation, DIC, or hyperfibrinolysis that can result from the ABL. The treatment for this is to use all transretinoic acid, ATRA, and that works specifically on the target of this PML RARA and enhance the differentiation of the cells. So instead of that differentiation arrest at promyelocytes, start forming more of myelocytes and metamyelocytes, and it goes into the rest of the neutrophilic series. So if you suspect this case, then you need to start ATRA as soon as possible, and you need to avoid invasive procedures. I think those are the two messages that I need general physicians to understand about this disease: is to suspect the disease, patient present with neutropenia or thrombocytopenia, and coagulopathy. Their fibrinogen will be low, their PT, BTTINR will be high. Clinically, they will have bleeding. They either having nosebleed or bleeding from any minor injuries. And this is how the promyelocytes looks like this is a bone marrow aspirate. You can see this our rods, multiple our rods in this promyelocytes. And it's rich granules. Some of the granules can release a lot of histamine and other chemicals that can lead to clinical DIC. So the coagulopathy is the main issue with this condition, and it happened from either DIC, low fibrinogen, and that will be due to hyperfibrinolysis. So any patient you suspect having acute leukemia, you order PT, BTTINR, and fibrinogen. If they are low, you have to suspect ABL as a possibility. If you have the ability to give ATRA, you can give the ATRA while you are waiting for the rest of the workup. If this condition is untreated, most of the time people will die because of either hemorrhage, they bleed either pulmonary hemorrhage or intracranial hemorrhage. And even in the first 2 weeks of the treatment, the risk of death is approximately 10 to 20% because of hemorrhage and infection. So this is kind of suggested guidelines for supportive care measures. So you need to institute ATRA without delay at first suspicion of the diagnosis, without waiting for cytogenetics or molecular genetic confirmations. You need to check the CBC and DIC panel, including fibrinogen, every 6 to 8 hours, and be very aggressive with replacement of platelets and fibrinogen. Either use a cryoprecipitate if you have it available, or if you don't have available, use a fresh frozen plasma, but cryoprecipitate will give you a better concentration of fibrinogen in less amount of volume. You don't do leukapheresis in patients with ABL, even if they do have high white blood cell count, because risk of bleeding is high. These patients may bleed from the central line and they will die. And avoid any lumbar puncture, and avoid placement of central line in people with suspected ABL. Most of the other stuff are mainly related to complications of treatment, but usually we try to avoid any invasive procedure that carries risk of bleeding during the induction period, because the risk of bleeding is high. We start ATRA as soon as we can, and then once the diagnosis is established, then you can add either chemotherapy or arsenic trioxide to treat the underlying condition. And again, this is a highly curable condition if managed appropriately, and if the patient survives the first 2 weeks of treatment, then the cure rate is extremely high, and that's what is very important, and usually happen in younger people as well. All right, now probably gonna switch gears here.
One question, Dr. Abdulraheem.
Yes.
Will fragmented cells be seen in patient with M3 AML, or our rods are sufficient to establish diagnosis?
Fragmented cells, you said?
I think they're talking about schistocytosis.
No, schistocytosis will not be that much helpful because most of the DIC can cause, destructions, and you will see some schistocytes that way as well. So TTP, usually the difference between TTP and DIC in general, which is in this case ABL, is usually you don't see that much of coagulopathy in TTP. You see thrombocytopenia, you have some kidney problems, you see mental status issues, you see fragmented neutrophils in the peripheral smear, but you don't see that much of prolongation of PT, BTT, and INR, and fibrinogen should be normal. The promyelocytes usually is characterized by hour rods and multiple hour rods, and they have a unique shape also under microscope. So if you have an hour rods in peripheral blood, that's actually makes a diagnosis of leukemia. If you see an hour rods and you're able to identify hour rods, I think that will be sufficient for you to establish diagnosis in combination with the coagulopathy. Usually neutropenia, thrombocytopenia, low fibrinogen, that will be sufficient. Schistocytes can be seen in both conditions, but TTP usually not associated with coagulopathy. And although, the patient will have some mental status changes and acute kidney injury and all the other stuff.
اوكي دكتور عبد الرحيم معنا 3 دقائق باقيه ما ادري كم باقي معك من السلايدز
3 دقائق اوكي خلينا نتكلم عن الهايبركالسيميا
ممكن نخليها 5 إلى 10 دقائق اذا باقي معك سلايدز كثيره نحاول نختصرها
طيب كويس hypercalcemia basically I will try just to focus on the main things and go over those. So this case, for example, a 47 years old woman, history of breast cancer, came with confusion, dehydration. You check serum calcium, it's 18, so it's elevated. Clinical examination showed hypovolemia, dehydrated, phosphorus is 5, creatinine is 2, albumin is 3.3. This is a case of breast cancer. Bone scan was negative, and so what you need to do in terms of treatment. So we will, let me see here. Okay. So malignancy-related hypercalcemia usually happen in 10 to 30% of patients with malignancy. It's very important that when you see that serum calcium level to correct it to the level of albumin. This equation here help you to make correction because sometimes people with hypoalbuminemia, the total calcium may be lower than usual, so their corrected calcium may be higher than what you see. Another very important point on the slide is hypercalcemia is a very important prognostic sign in patients with solid malignancies. In people who presented with hypercalcemia or develop hypercalcemia during treatment, their prognosis usually is very poor. Usually we see it in advanced malignancies and advanced cancers. Most of those patients will die in the first 30 days. All right, let me see. Okay. This slide is very important here. The mechanisms of hypercalcemia associated with cancer. It can be either due to bone metastatic disease, or it could be related to what we call
دكتور عبد الرحيم ما في صوت ما في صوت فقدنا الصوت مرة أخرى يا دكتور
Hello?
لو تعيد السلايد يا دكتور، ما سمعنا شيء. السلايد اللي قبل هذا.
اوكي. في السلايد هذا بس we talk about the mechanisms of hypercalcemia in malignancies. More than 80% of times it usually related to release of PTH related peptides. In 20% of times it's due to direct bone mets, local osteolytic hypercalcemia. Very rarely you see 125 hydroxy vitamin D secreting tumors, mainly in lymphoma. And very, very rarely you see some BTH ectopic production, usually in germinomas or teratomas. For workup of those, the very important thing is to do the PTH. PTH will help you in identifying the mechanisms of hypercalcemia. So once you have the hypercalcemia confirmed, you can measure the PTH. And if the PTH is normal or low, if the pH is normal or high, then you are dealing with non-malignant process. If the PTH is suppressed, that's mean more likely you are dealing with non-PTH mediated hypercalcemia, and malignancies at the top of the list. Then you do the PTH related peptide. If it is high, then you are dealing with malignancy. If 125 dihydroxy vitamin D is elevated, then more likely you are dealing with either sarcoidosis or lymphoma. So this kind of the workup that will help you. If the BTH related peptide is negative, vitamin D, either the 1 or 25 are low, are normal, then you need to do workup for multiple myeloma, which is a very common cause of hypercalcemia. Treatment, usually the main initial treatment is IV fluid. So in the emergency department, you need to, those people who come and present with hypercalcemia, they will be very dehydrated. Their intravascular volume will be very low. Usually they have acute renal failure, pre-renal acute renal failure. So it's very important that you give them fluids, give them 2, 3, 4 liters of fluids as boluses to replenish their volume status. And then after you give the fluids, then you can diurese them. So you need to fill the tank first, and then you can diurese them to help in getting rid of the calcium. Calcitonin may be helpful, and it works. Onset of action is 4 to 6 hours. The mainstay of treatment will be mainly the bisphosphonate, either zoledronic acid, bamidronate, or recently approved denosumab as well. So those usually have a slow onset of action, usually can take anything between 24/7 to 2 hours to work. So you can administer it on the first day if the kidney functions will allow that. But the main initial treatment is IV fluids to replenish their volume status. And of course, in severe cases, you may end up needing either dialysis or steroids based on the etiology. Okay, let's take this case. 65 years old, male smoker, presented with non-productive cough, dyspnea and exertion, hoarseness of voice, and a 3-month history of progressively enlarging veins over the anterior chest wall, as you can see in this picture. Chest imaging study, as shown here, showed there's a small nodule in the right subpleural upper lobe, and then there is a large mass in the paratracheal area that causing complete occlusion of the superior vena cava. Biopsy was obtained, and it confirmed small cell carcinoma. So we are dealing here with one of the oncologic emergencies called superior vena cava syndrome. So malignancy-related superior vena cava syndrome is a condition that results from blockage or obstruction of the superior vena cava. Most of the time, the obstruction will be malignant due to either direct invasion by a local tumor or external compression of the SVC. most of the time that blockage may be associated with thrombosis as well. And now increasingly with increased use of central lines, either hemodialysis catheters or pacemakers or central venous catheters, people may develop thrombosis in the superior vena cava, and if it is severe enough, causing complete obstruction, the patient may present with superior vena cava syndrome. Presentation, usually patients present with facial and upper extremity edema, chest pain, respiratory symptoms, and in severe cases, neurologic manifestations. There is grades for severity of malignant superior vena cava, starting from grade 0 to grade 5. 0 asymptomatic, just found in the CT scan. They do have some obstruction based on the CT scan, but clinically, patient does not have any symptoms. And grade 5 is in the other scale, but patient is dead. In grade 1, usually patient will have some mild edema in the neck. There will be some vascular distension that you can see, cyanosis, plethora in the face. In grade 2, which is moderate, you will see more swelling in the head and neck area. There is some functional impairment like dysphagia, cough, some difficulties with jaw movement or eye movement, some visual changes caused by ocular edema. So you see some changes there. In severe cases, that usually results, and the unique part about this case, severe or grade 3, is cerebral edema. So patient will have headache, dizziness. They may have some mild to moderate laryngeal edema. Also syncope after bending is also another symptom. In very, very severe cases, which is life-threatening, that happen when there is more cerebral edema and significant laryngeal edema and stridor. Mainly stridor is an emergency, as you all know, but when it's combined with superior vena cava, it indicate that it's an emergency need to be acted on immediately. So a very important thing here, if somebody present with a stridor, distended chest wall veins, swelling face, that will be the kind of a person that you will need to act on immediately. It represents a true emergency, and you need to initially stabilize the patient, and the main thing is to secure the airway and the circulation. Once you secure the airway and circulation, then this patient may need, an endovenous intervention for treatment of the severe vena cava syndrome with placement of stent. Otherwise, the mortality rate will be very high. This is a very busy slide here, but to summarize this graph here, if the patient is mildly symptomatic, meaning a grade 1 or grade 2, that means there is time for you to do an appropriate workup, find out etiology, and decide what will be the best treatment that you can do. If the patient is grade 3 or grade 4, meaning they are sick and very symptomatic, then you don't have that much time. You need to stabilize airway and get them to either vascular surgery or intervention radiology. They may need to do a venogram and endovenous stent. And then after the stent, you may need to establish the exact etiology with the biopsy and then decide on treatment, what you need to do if this is a cancer. For the mildly symptomatic cases, you may elect to do some appropriate workup first, the CT, chest, abdomen, pelvis, and MRI of the chest, try to find out the exact stage of the cancer, and then do biopsy at the same time. If the etiology of the obstruction is chemosensitive, then you may elect to treat with chemotherapy as the first treatment. Examples of chemosensitive tumors are small cell lung cancer or lymphoma or germ cell tumors. If the cancer is not chemosensitive, meaning you would not expect a significant response from chemotherapy in a short period of time, then you can think about radiation as an option or endovascular stent as an alternate option as well. The benefit of the stent, it gives you an immediate relief of the obstruction. Most of the symptoms will get better, and that will give you time to actually proceed with appropriate workup and decide about definitive treatment later. And this basically just talking about the same thing. And I think I will stop probably here, and we'll be more than happy to take any questions if you guys have.
دكتور عبد الرحيم، النقطة هذه الأخيرة radiation مثلا لازم يكون بعد أخذ العينة. تفضل.
Yes. You know, radiation and chemotherapy will not work immediately. You know, it takes, it's gonna work over, you know, you need to have a week or two to get the response that you can see. So if you're gonna use radiation or chemotherapy, you need to have a sample. So we usually consider that after tissue diagnosis, yes.
Even if the patient is established?
If it is already known to be diagnosed, like, you know, you had somebody who had a biopsy 2 weeks ago and it's been confirmed, and now it just came with these symptoms developed before you start treatment, yes, then you don't need to wait. You can start radiation right away if he is stable to handle radiation, yes.
And what is the role of steroids in some of the tumors here?
Yeah, so apparently steroids, there is a controversial rule about steroids, especially if you're running into a laryngeal edema and a stridor. I think there is a big rule that way. It just mainly for the airway issue. There is no rule in terms of managing the SVC itself. It's mainly, it may help with the laryngeal edema and things like that. So it will help with airway protection, but it's not going to be, you know, the main treatment changing or the course changing treatment. You will need to have a more definitive approach, either by getting them to vascular surgery or interventional radiology to do venogram and put stent. Or you start them on a more definitive treatment. Another very important subject here is the anticoagulation as well. Most of the time, the external compression will cause narrowing, and then it will be superimposed thrombus on that. So we use a lot of anticoagulation if there is no contraindication. You have to make sure that there is no contraindications for that. Untreated brain mets, bleeding, you know, high risk for bleeding, it may be a contraindication, but if there is no contraindications for anticoagulation and there is evidence of thrombosis on top of the tumor, then you do add an anticoagulation. It may help a little bit. If there is airway compromise, if patient has stridors, airway issues, steroids may help, but I probably will not use it outside that situation.
And going along with that, steroids can affect the, you know, the architecture of lymphoma cells. This is another question.
If it is a lymphoma, then I don't you know, and the patient is you know, has a life-threatening issue, you probably want to save the you know, the patient life. I probably will give steroids even if I don't know the diagnosis, if there is airway compromise, and if you know, and it depends on the clinical scenario. If somebody is young, came in with cervical lymphadenopathy and mediastinal mass, and you have a high suspicion of lymphoma, if they are symptomatic enough, then you may give them steroids. I don't think the course of steroids 1 or 2 may change the architecture of the biopsy. You still will have a very good biopsy results with that. It may help in saving the patient life, especially if you don't have that much access to, you know, an airway or anesthesia or, you know, an ENT for tracheostomy or anything like that. But in people with the classic SVC due to lung cancer or non, you know, or thrombosis, I probably will use it only if there's an airway issues. If the patient is stable, I will not do steroids at all.
اوكي. احد عنده ملاحظه اخرى؟ اوكي، في سؤال هنا. Thanks, I'm really sorry for my annoying questions. No, you're welcome دكتور محمد. بالعكس اسئلتك جميله، الله يبارك فيك. دكتور، ما في احد تقريبا عنده ملاحظه. محاضره قيمه نشكرك عليها، الله يبارك جهدك وتعبك، الله يجزاك خير. معنا الدكتور أحمد باذيب، شوفه مشارك، ممكن نسمع تعليق بما أنك قريب من الحدث يعني. الدكتور أحمد لا يسمعنا الظاهر. طيب، هو الدكتور أحمد عنده محاضرة الأسبوع القادم بالاشتراك مع الدكتور محمد العمري، فحتكون إن شاء الله Oncology وسيرجري مع بعض. بتكون محاضرة عن البريست كانسر، workshop إن شاء الله. ستمتد تقريبا هذه المحاضرة أخذت ساعتين اليوم يمكن، ولا تقريبا ساعتين إلا ربع، ممكن في نفس هذا الوقت المحاضرة القادمة إن شاء الله. الدكتور عبد الرحيم، ملاحظة منك ولا شيء قبل ما نختم؟
أشتي أسأل أنا إذا في أي حد في شبوة أو في اليمن، إذا في عندهم أي سؤال أو حاب أعرف إيش النوع الإمرجنسيز اللي يشوفوها وفي عندهم صعوبات في التعامل معها يعني في البلاد.
نعم. واحد من الشباب يتبرع أو من الأخوات يحدثنا عن الهيمونك Emergencies. إيش أكثر الحالات اللي بتشوفوها؟ وإيش الصعوبات اللي تواجهوها؟ دكتور عبد الله غير مسموح لأنه في بريطانيا الآن. طيب دكتور محمد باذيب.
أبو غيث يفوت بأي وقت يا وليد، أبو غيث في أي وقت يخش على
دكتور
سلام أستاذ الغالي.
الله يسلمك. دكتور عبد الله، انت قضيت وقت طويل من عمرك في البلاد، الله يحفظك. ايش الهيمونك امرجنسيز اللي كنت تشوفها انت من وجهة نظرك او خبرتك السابقة، ومن تخصصك في الامرجنسي الان؟
أول شيء نشكر الدكتور عبد الرحيم، ما شاء الله محاضرة طيبة و very useful يعني. أنا طبعا لي من البلاد زمن طويل، لكن I think common is common يعني. I think the fever is the most commonest thing. Wouldn't have in my days, be honest, there is any center in Shabwa. Possibly nowadays they have some oncology center there. I think they started to seeing patient with complications. Possibly those who are on the ground, possibly they will benefit more. دكتور عبد الرحيم، شكرا جزيلا، محاضرتك طيبة راقية جدا ورائعة، واستفدنا منها حيث ما كنا. أنا هنا أدون طبعا محاضرتك جميلة جدا، شكرا جزيلا.
طيب، في ملاحظة أخرى، الله يبارك فيكم جميعا. طرحت عنوان الصفحة على الفيسبوك قبل ما يخرج. أنا عندي الآن قد وصلنا إلى قريب 40 شخص، لكن لهم الآن 23. أريدكم جميعا تنضموا إلى الصفحة هذه، لأنه التواصل على المحاضرات القادمة سيكون عن طريق هذه الصفحة. رابط المحاضرة هذه save the recording على الكلاود. I will send it to this page as well. يعني كل أي تواصل قادم مع المحاضرات برسلها هناك. أيضا بنحاول نجيب الليكتشر حق اليوم، الباوربوينت سلايدز إن شاء الله من الدكتور عبد الرحيم، ونضعها هناك إذا أذن لنا أبو أكرم. أعتقد هذا كل ما في الأمر، والله أعلم. أي حد آخر عنده ملاحظة؟ ما فيش، ما أعتقد. طيب، بارك الله فيكم جميعا، استودعكم الله. المحاضرة القادمة يوم السبت الساعة 1 مساء، عفوا 9 مساء بتوقيت اليمن. كل المحاضرات ستكون السبت 9 مساء. اللينكس سيكونون مختلفين مع باسوردز مختلفة كل محاضرة، ولذلك المتابعة عن طريق الصفحة أفضل طريقة للتواصل. نقطة أخيرة، سامحوني، أي طالب طب في المراحل الأخيرة من الدراسة، أعتقد المحاضرات هذه قيمة بإذن الله. نحاول نركز على البيسكس زي ما تشوفوا، حاولنا يعني أن نكون very basic مع الدكتور عبد الرحيم. أعتقد أنه لو أراد التوسع لتوسع، لكن بارك الله فيه يعني حاول أن نوصل الصورة للجميع. فطلبة الطب آخر السنوات they are welcome. بالعكس I will encourage them to attend. أي أحد من أي محافظة أخرى من أي بلد أيضا welcome. العدد سيزيد مع الأيام، ممكن ننقل لايف ستريمينج عبر الفيسبوك إن شاء الله. في أمان الله جميعا.